Hello, friends. Welcome to our live webinar. Many of you I was just talking to on Instagram. Welcome, welcome. We're going to give it a few minutes for people to log on. You are in luck tonight. We have such an excellent program planned for you. And we promise to send out to the recording for anybody who can't make it live. We're going to give it another 45 seconds. Give us a hello in the comments. Tell us where you're from. We're so happy to have you. Welcome, welcome. And make sure you put your Q&A, your questions in the question box. We're going to answer lots of questions tonight. So just going to wait a few minutes.
And hopefully everyone really laughs at the play on words. We've been using AI a lot to help us with like really fun, hashtags and catchy slogans for webinar names. So hopefully it gave you a chuckle. One of my other favorites is I laughed so hard the tears ran down my legs. So that you won't see in here, but is one of my also favorites.
I have a feeling that they are not able to go into the chat, which is probably why people are raising their hand right now. Yes, so they're just going to go in the Q&A. We'll see if our team can fix that to allow for the chat to be open. But in the meantime, we're going to wait one more minute. We are so happy. Yep, the chat's disabled. I was right. I knew it happened. We are going to get started in just 30 seconds. But we are so happy. We have a great showing tonight. So really looking forward to having this discussion. All right, it's 8:02. Welcome, everybody. I'm Dr. Rachel Rubin. I am so honored to introduce my dear friend and colleague, Dr. Christine Vaccaro. So for anyone who doesn't know me, I am a urologist, fellowship trained in sexual medicine, and we have a growing, wonderful, incredible practice both in the Washington, D.C. area as well as in Los Angeles. We begged Dr. Vaccaro to join us earlier this fall, where she retired 30 years in the military, and she is a urogynecologist. So I'm a urologist. She's a urogynecologist, and she'll explain all of those things. Go to the next slide, Dr. Vaccaro, because I want people to see all of the amazing things that have brought you to us. She gets her medical degree from the University of North Texas. She did her residency at Madigan Army Medical Center. She did her fellowship in Cincinnati, Ohio, and we've done advanced training together in sexual medicine, which is just an absolute joy. So Dr. Vaccaro is in our practice and sees people for menopause issues, lots of hormones, pelvic pain, urinary incontinence, pelvic organ prolapse, which I'm sure she can talk at length about all of those things. It is really, truly not only personal, as I've had 2 babies myself, but I've had family members suffer with urinary incontinence, and it is an unbelievable effect on people's quality of life. And so many people think they just have to suffer, they just have to put up with it. And there is so much we can do to help alleviate suffering in people with incontinence. So we are just so honored to have Dr. Vaccaro. We know this is a hot topic, and we'd love to bring you more webinars, more live Q&As as we grow our practice. If anyone wants to come to the Washington, D.C. or Los Angeles area, we'd love to help you in any way possible. So I'm going to give it over to Dr. Vaccaro. I'm going to chime in and we're going to do lots of Q&A throughout. So we are just so thrilled to have you. Take it away, Dr. V.
Thank you so much, Dr. Rubin, for the lovely intro. And I'm excited. I'm really excited for those that showed up tonight to learn more about yourself, to learn about all the therapies for urinary symptoms, because again, just like Dr. Rubin said, none of these things do you have to live with. So bladder symptoms do not need to disrupt your life, but oftentimes they do. So these are various different scenarios that I hear about all the time. Again, the DC traffic is really horrible. So again, oftentimes women are talking to me about how it's difficult even to make it to our office for a 1-hour drive because they feel like they have to constantly stop or toilet mapping the beltway. So again, going to the bathroom frequently can be very, very bothersome. Not being able to sit through an entire movie. This is one of the questions I always ask, like, how often are you going to the bathroom? Can you sit through an entire movie? And oftentimes women are like, no, I'm actually going to the bathroom every hour, or I have to fluid restrict to even just be able to go and sit with my partner and sit through an entire movie. And then again, just being, very concerned, anxious, worried that they're going to have an accident and not be able to get to a bathroom on time. So these things are very, very disruptive to a woman's quality life. And I often get, well, this is just a normal part of aging, or it's just a part of being a woman, or maybe I did something wrong to cause this. None of these things are true. This is not a normal part of getting older. It is not normal, though it is very common. And often, and also, just so you know, men also have leakage. It's not just women. And again, all these things are absolutely treatable. So again, Dr. Rubin and I are both huge advocates on quality of life, right? It's great to be living and know all the things, right? But what about your quality of life? So we want you to have a wonderful quality life, not be limited by your physical activity. So I often have women say to me all the time, like, oh, I'd love to get back in the gym, but I'm either constantly leaking when I work out, do jumping jacks, do things, I have to wear large pads, or I have to, go to the bathroom multiple times during a workout, and it makes them not want to do those things. I have women often tell me they don't want to leave their home for fear of leakage. So they start withdrawing and staying in and limiting social interactions. I have a lot of women that just start having depression or just, again, loss of respect for themselves and because they're limited. We see a lot of patients in our practice for sexual medicine complaints. And of course, fear of leaking on your partner can be really adversely affecting sexual intimacy. And then occupationally, women will sometimes stop going to work because, again, fear of leaking. And then again, just as a whole economic society, the pad industry is a huge billion-dollar business. But pads are not the only way to treat and manage urinary leakage. And we're going to go through all the things. So I'm glad you're here. Hopefully, you're not alone, because obviously there's a lot of women here tonight. So again, 30 million women will suffer from stress incontinence. So that's 1 out of 3 women at some time in their lifetime. I'm going to go through what stress incontinence is, but hopefully you understand what a huge impact this is as far as the number of women it impacts. So let's go into the nitty gritty. So stress incontinence means there's like a force, whether that be a cough, a sneeze, a lift, a laugh, that puts pressure on the bladder. And the urinary sphincter, the muscle that controls our bladder, is not strong enough to withhold that pressure, and urine will leak. And usually, again, it's a very quick force, and a few drops or even a little bit more will come out. Again, this is very common. I get this almost every day, and it can be as mild as a woman that says, you know what, I just don't jump on the trampoline anymore, and if I don't do that, I don't leak. Jumping on a trampoline is one of the most stressful forces you can put on the bladder, because it's like 4 times your body weight. So a lot of women after one kiddo are like, you know what, I just don't jump on the trampoline anymore, and that's maybe all they need to do to modify their activity. Take that to the far other extreme. I have women that just simply getting out of a chair or just simply walking, meaning 1 foot down, will cause urinary leakage. So there's a huge range in severity, and it only really matters when it bothers you, right? That's really when, most of the time women are coming in to seek treatment. And the good news, of course, which is why you're here, is there's so many treatments. And this is kind of like the pillar, the way I think about treatments for stress incontinence. Again, this is leakage when you cough, sneeze, lift, laugh. So there's pelvic floor physical therapy. I'm going to talk about another therapy that's not on here called pessary. There's urethral bulking and Sling procedure. So always want to start with the most conservative things first, if possible. So again, there's so many lifestyle changes, but again, some of these are kind of a little bit difficult, right? I often have women say, well, I'd really love to work out again, but every time I work out, I leak. So that's preventing me from working out and losing weight. So again, that's a little bit of a difficulty. Now we have, of course, other therapies for weight management like GLP-1s, et cetera. So there's other things coming on the market that are going to help, I think, with weight management. But the idea here is reducing any excess abdominal forces. So when you laugh, cough, sneeze, if there's a lot of abdominal weight that's also pressing on the bladder, that can make stress incontinence worse. And then, of course, smoking is bad in general, right? But again, if you're smoking, and then you have a chronic cough, or even chronic asthma, things that you're constantly coughing, over time, that really puts a lot of stress on the pelvic floor. And again, all those coughs add up to generally more leakage. Every woman should do Kegels. Kegels are really great for prevention of pelvic floor disorders. But sometimes, again, women, because we're not great at figuring out how to use those muscles, you do want to make sure you're doing them correctly. A lot of times Dr. Rubin and I will send patients to pelvic floor physical therapy to make sure that you're doing those appropriately and have a great provider helping you through this. All right. A really wonderful non-surgical therapy that's office-based is called a vaginal pessary. This is a very flexible silicone, medical-grade silicone device that we fit you for. It's similar to like a diaphragm, and we fit you for it in the office. And you can see on the picture here, there's a little knob, and that knob preferentially supports the urethra, because a lot of times, again, the urethra just needs a little extra support. And then this is a really nice therapy, again, if it's like, you know what, I only leak when I'm doing heavy exercise, or I only leak when I have a really bad cough or infection. It's something that's really nice to be able to self-manage. Really, really nice, flexible therapy option. Another relatively newer agent is called Bulkamid, or a bulking agent. There's been a variety of different components through the years. It used to be collagen. That's now off the market. And now this new hydrogel is kind of like the mainstay for urethral bulking. But this is a really nice procedure. There's no incisions. It's an outpatient procedure. It usually takes just a few minutes. And I'll show you a little video about how this is done. But it's a really, really nice therapy to allow women to go right back to activities without any downtime. So again, it's called Bulkamid, which is the bulking agent. And again, it is a very flexible water-based gel. It's almost 99% water, actually. It's just cross-linked, so they call it a hydrogel. But it does not interact with other tissues. People are not allergic to it, because again, it is mostly water. And it is designed to be permanent. So unlike other, like maybe facial fillers that people get, this actually doesn't go away or get absorbed by the body. It actually stays put, which is really nice to keep the therapy going. So I'm just going to play this little video because I think it sort of summarizes what it is.
Is there sound on the video? Because we can't hear it.
Oh, you can't. Okay, so all these little cushions are where the hydrogel goes through a little incision with a needle. And you go back to activities almost immediately, meaning it's like a 15-minute procedure. And again, it is performed usually in like a surgery center for your comfort, because it does not feel good to have a needle in the urethra even just 4 times. That's not comfortable for most patients. So generally we do that in a surgical suite. All right. Sorry, I thought everyone could hear that. So this is just another way to see this. Again, you can see at the bottom all these cushions. This is the hydrogel, 4 different places, and then in the middle is the opening that goes into the bladder. So again, these cushions just help support the base of the bladder, so there's no leakage. Again, we could talk about like having a really nice coaptation or a proper seal so that you stay dry. All right, so what does the data show about Bulkamid? It shows that 92% of women are improved or cured, which is a really wonderful therapy. I do find a lot of times that women need a touch-up procedure. So it's generally, I say like the first time we do it, most women are like 60% of women are like, that's all I needed. But about 30 to 40% of women will like say they're improved, but still want a little bit better. And generally then we do another touch-up procedure. Meaning repeat the procedure to get a little bit more effect. Again, 15-minute procedure. I do this in an outpatient surgical setting because I don't think local anesthesia is quite enough to be comfortable. I don't like people being in pain. And again, we have now 7-year data on Bulkamid. So, and again, we have really high success rates. Next is a surgical sling, and this is generally sometimes referred to as mesh. And this is actually still considered the gold standard for treatment of stress incontinence because the primary mechanism of stress incontinence is poorly supported urethra. So again, by giving it like a little hammock of support, this is curable with a 30-minute outpatient surgery. And again, we have 17-year data on the slings with excellent efficacy and excellent safety. There was a concern about 15 years ago with all types of mesh because the success of slings. Instrument companies made another product for prolapse, which we're not going to get into tonight, but they put huge pieces of mesh in the vagina, and that created issues and made all mesh seem bad. But surgical slings are a very small strip of mesh and have always been deemed safety. The FDA supports the safety and efficacy of slings. The risk of a mesh complication is about 2%. And generally what that is a small exposure in the vagina, which then we need to close the incision. So if you're at all concerned about the safety and efficacy of mesh slings, please know that surgical slings are very safe and effective. Okay, we're gonna switch gears to overactive bladder. So this is I gotta go, I gotta grow it now, get out of my way. I'm trying to get my pants down and hoping that urine doesn't start as I'm trying to get to the bathroom. 50 million women in the United States will have overactive bladder, but only half of those, even with severe symptoms, will seek treatment. Again, I think women are just either embarrassed, they don't know there's treatments available, they can't find access to a practitioner that is going to offer them good therapies, but no woman needs to suffer with any of these types of leakage. So just to review, a normal bladder function when it's in the storage phase, basically the bladder should be filling easily without a lot of squeezing and contracting, and the urethra should stay closed. When we sit down on the toilet to empty the bladder squeezes and the urethra relaxes to allow emptying. The problem with overactive bladder is sometimes the bladder contracts and the urethra is not strong enough to hold it back, and that's when leakage occurs. And that's again very, very frustrating. So again, sometimes we have patients that have what we call overactive bladder dry, meaning they just feel like they have to go to the bathroom all the time, but they're not leaking. But then we have overactive bladder wet, which is women that feel like they have to go and then do have urinary leakage on the way to the bathroom. Overactive bladder can be a huge range of how often women go. I mean, I've had women, go as often as every 15 to 30 minutes during the day and, multiple times at night, or it can simply be situational based on what they've eaten or what fluids they've had that day. So it can really vary symptom-wise. But again, it always generally has going to the bathroom a lot, usually more than 8 times in a 24-hour period, feeling a sudden urge that you can't control, having some leakage on the way to the bathroom, and then getting up more than 2 times a night, which is super frustrating. I think one of the most frustrating things with this is the disruption in sleep, and a lot of women can't get back to sleep once they get up to go to the bathroom. And again, sleep is like the foundation of wellness, and it's really, really bothersome and takes a hit on every aspect of life when we can't get good sleep. Okay, good news again. There's great treatments for overactive bladder. So really, where's the pathway? Obviously, start chatting with a provider. It does not have to be a urogynecologist. A lot of primary care doctors have some knowledge of overactive bladder. So if you love your primary care doctor, certainly you can start there. Generally, you want to have some sort of diary of your symptoms, like how often you're going, how often you're leaking. It's really a good idea to make sure you don't have a urinary tract infection. If you follow Dr. Rubin at all, you know that she talks all about vaginal estrogen and reducing UTIs, because about a third of patients that have overactive bladder also have a UTI at the same time, and they don't even know that they have the UTI. And that's creating a lot of extra urgency and discomfort and making the bladder very irritable. So a lot of times we have to treat the UTI as well to really improve the symptoms of overactive bladder. And of course, there's all sorts of conservative treatments. Number one, we know that vaginal hormones, especially estrogen, really help overactive bladder. So if you're in that perimenopause, menopause timeframe and you just started having overactive bladder symptoms, I'd really advocate for a trial of a vaginal hormone therapy. And then this is a great place to make sure that you know how to do proper Kegels, seeking out a great pelvic floor physical therapist. There's so many wonderful providers in the DMV area. And they really teach you how to control the pelvic floor. If you can squeeze your pelvic floor long enough and strong enough, it actually sends a signal to the bladder to tell the brain, oh, hey, this is not a socially acceptable time to empty. And the brain tells the bladder to relax. But if that signal doesn't get sent, the bladder thinks it's socially acceptable time and just continues to squeeze. There's also medications that we can use to relax the bladder, and there's some newer ones on the market that don't have some of the nasty side effects that some of the older therapies had. Some of the older bladder medications called anticholinergics cause a lot of dry eye, constipation, and also can cause cognitive decline. So those aren't generally wanted for anyone. Now, some of the newer therapies, medications really have very few side effects. So just know there are some medications that can relax the bladder that don't have some of those negative side effects. And then, of course, there's advanced therapies. So, but before we get to advanced therapies, just know that 80% of patients that are given a medication, meaning a bladder relaxing medication, this is not vaginal hormones, this is bladder medications, specifically discontinue within a year. So what that tells me is these aren't really great therapies. Either they're not working that great, woman still is having leakage, or they're not taking the medication, or for some reason are having side effects, again, dry eyes, dry mouth, constipation. Most women don't understand the cognitive decline until it's happened, and then it's a little bit too late. So initial treatments, again, involve educating on, again, pelvic floor physical therapy, bladder training, lifestyle changes. There's a whole bladder diet, but just very briefly limiting acidic foods and fluids, specifically coffee, which every woman hates when I say that. But coffee is very acidic and irritating and is a diuretic, so it fills the bladder fast. And those are generally not great things for overactive bladder. And of course, discussing prescription meds. And then I'm going to get into these advanced therapies one by one, so you know all the menu of options available. So one of the newest tools in my toolkit is Bladder Botox. So I'm sure you've heard of Botox for your face, for wrinkle prevention. It's used for all sorts of different conditions, but basically what Botox does is it relaxes muscles. So we can inject it into the bladder to make the bladder not be able to squeeze as hard, which makes urinary leakage less likely. And it has one of our best, what we call dry rates of any of our therapies. And it's nice because there's no long-term anything. There's no implant. There's no incisions. The downside is it does need to be repeated every 6 to 12 months to maintain the effect. So for that reason, and it's not a super comfortable procedure, 60% of women will discontinue after a few injections. Generally, that is, in my opinion, because they realize there's other therapies that might give them more substantial long-term treatment options, like what I'm going to talk about next. But it's a really nice place to start for a lot of women. So next is sacral neuromodulation, and this really targets the nerves that go directly to the bladder. So I like to think about this like a pacemaker for the bladder. It basically is like a little bit of a jump start to make the bladder work better. So we do basically a trial therapy using a local anesthetic. Usually, again, this is done in a surgical center just to make sure it's nice and comfortable. And then after a successful trial, which usually is a 1-week trial, if the patient is doing much better, meaning greater than 50% improvement in urinary leakage and urgency and nocturia, then we go on to do a full implant, which is a very small and discrete implant, which I'll show you next. So the therapy that I use is called axonics therapy. And again, it has lots of indications, but tonight I'm just going to focus on the overactive bladder component. And again, what this does is it helps kind of like communicate the different signals between the brain, the sacral nerves, and the bladder to help establish normal communication. A lot of times the nerves are just dysregulated and need a little modulation. So this is what the therapy looks like, and there's two different sort of like models. One is a fully rechargeable device, which is on the left, and it's a very small device. It almost looks like a thumb drive, and it's placed under the skin of the buttock, so kind of in the meaty. Everyone's got a little bit of a meaty portion of the buttock, and that's where it goes. And the nice thing about this is it's recharged every 6 to 10 months. So that is not a whole lot of effort for something that would provide lifelong therapy. There is another option though. There's a non-rechargeable option that it looks like it's about the size of a $50. And this you don't have to recharge at all and lasts for 10 to 20 years. And my patients, they ran an analysis and mine lasted 19 and a half years on average. And it all has to do with how close it gets placed to the nerve. But again, it just depends on kind of what kind of therapy you're looking for. All of these devices are MRI compatible, which is a really nice thing for patients that might need imaging. Again, there's a really small pocket remote that helps control the therapy. It's very easy to use. It doesn't ever need to be recharged, which is also really nice. I'm still not sure how they do that, but it's a really, really patient friendly. So for sacral neuromodulation, there's a 93% success rate with clinically significant improvement of incontinence at 2 years, which again, wonderful. In medicine, we don't often get these high of success rates for anything that we do. And then again, 94% of patients are satisfied and 93% would undergo the therapy again. Again, really excellent numbers. This is the poster child. She was one of the first patients to undergo axonics therapy and is a huge patient advocate. I do love that this company allows patients to communicate with patient ambassadors to make sure they understand the therapy and ask from a patient perspective questions. So this company invests in their customer service and ambassadors. Okay, that was really down and dirty. I'm just going to kind of flip through these slides. This is our office, our number. I do not have the followers Dr. Rubin does. I aspire to be her one day, but my social media is building. I am going to start a 30-day series on everything related to urinary incontinence. So if you want to follow me on social media, that will be starting this week. So
everybody follow Dr. Vaccaro. She's amazing. This was so excellent. Why don't you unshare your screen so we can see you big and bright. I am so thrilled. There are tons of questions. We have tons of engagement, which I love to see. People are so curious about this topic. You know, this is a topic that is so near and dear to my heart because it's very personal, right? I had 2 babies. When I'm doing the dishes, sometimes, if I'm not careful, if I sneeze or cough or, we call it sort of the doorknob. You go to put your keys in the doorknob and you're like, I gotta go. I can't get there fast enough. And I'm a urologist. I know this is a thing. And I have to explain to my husband, like, no, this is like actually a thing that sort of affects the bladder. And really, for a quality of life thing, I'm going to share a story with everybody because I think it's really important that we understand that this isn't just a little bothersome. I mean, urinary incontinence is hugely, hugely bothersome. The amount of money people pay on diapers, on pads, on on sheets, special absorbing sheets on their bed, the fact they won't be with their partners, that they're embarrassed, they won't go play with their grandchildren, they won't do all these things. It's huge. My mother just died in November after a long lung condition where she was coughing all the time. And she would cough and she would cough. And when she coughed, she would leak. And she was so miserable. And she ultimately died of her lung condition. But several years before, it was COVID. And she was so miserable, coughing and leaking. And I ended up asking a friend of mine in Texas where she lived to put in Bulkamid for her. I was so excited when Bulkamid came out because it was minimally invasive. It was something she could do. She didn't have to undergo anesthesia, which we were afraid to do because of her lungs. And it gave her so much relief. It was so powerful. It worked for quite a long time until her lung condition worsened. And she ultimately coughed right through her Bulkamid after a year or so and ended up getting a sling. And I can't tell you how impactful it was that at the end of my mother's life, that she didn't have to worry about urinary incontinence, that it wasn't a bothersome thing for her, that she didn't have to wear diapers, the dignity that goes with not leaking. I just, it's so personal for me, and my ability to advocate for her to get those quality of life procedures that ultimately I think just gave her so much quality of life towards the end. And I'll forever love the urologist who did that for her. So I wanted to share that story with everybody because it's okay to want a good quality of life. It's okay to not want to leak when you cough, laugh, or sneeze. And we treat women with this ability to say, well, just suck it up. This is aging. You have to live with this. But thank God for these innovations that are really allowing a wide range of therapies from conservative to more aggressive, but even the aggressive options really are not, of course, there's bad things can happen, but are really a very safe and effective, and I know you see this all day, every day, but I think the average person doesn't realize this.
I totally agree. And I thank you for sharing that story because I know it is deeply personal for you, but it is so, the impact on society for women and leakage is massive. It cannot be underscored enough times. No woman needs to suffer. There are wonderful treatments. And again, you and I love to say, like, we'll just meet you where you are. Like, if you want to maximize conservative therapies, I will talk to you all day about how to do that and work with a pelvic floor physical therapist and do all the conservative things first, but also knowing that all of our therapies are minimally invasive. Like, there's no long surgery for urinary incontinence. There's no long procedure. These are quick in and out procedures that restore women back to their lives very quickly. So
Now I want to speak, I want to give a plug, and I know you mentioned this, and I can't not mention loudly vaginal hormones, which you already mentioned, but everyone who has urinary incontinence, whether it's stress or urge, whether you are 35, 40, 45, 95, and we've gotten this question in the chat, should be on vaginal hormones. Why? Because they can't hurt you. They not only can't hurt you, they're totally safe for you and your partner. They will prevent urinary tract infections by more than half. I think of it like the only essential oil that is truly needed. You can use it if you've had a history of blood clots or heart disease, or even if you've had cancer history. It is safe to use. And we're very excited because, if you don't get our newsletter, you better get our newsletter. We're going to put our newsletter in the chat box in a second. But it's so important because there's some big news coming out, some very exciting news coming out for advocacy around the safety and efficacy of vaginal hormones, which we're very excited about. So if you're ever going to get treated for your incontinence, the foundation, in our opinion, is really vaginal hormones. And you may see that urgency or those stress symptoms get a little bit better because you're supporting the pelvic floor, you're supporting the tissue, you're making it a really healthy, which is so fabulous. Okay, so we are going to get into question and answers, which we've got lots of time for. I'm so thrilled that you're all with us tonight. The fact that you're spending our Monday evening with us, we are so honored, and we've got people from all over the world here, which is just so fabulous. So make sure you put in that chat. I'll read it out because you guys can't see each other's chats, but we've got someone here from Central Florida, from Canada to Newfoundland. Juneau, Alaska is here tonight, which is just so fabulous. So now many people travel to see us. In fact, just in the last week, we've had people from England, we've had people from other parts of Europe, we've had people from all over the globe come to see us because we spend a lot of time with people and we really dive deep into like really getting to know you so that we can meet you where you are. It's so not a one size fits all, whether it's, and really looking at your hormones, looking at your pelvic floor, looking at pain, looking at your sexual health. You deserve like someone who looks at all of you. Dr. Vaccaro, speak to just what it's like to spend time really getting to know your patients and diving deeply.
Yeah, I mean, again, 90 minutes, even though I thought, how can I possibly spend 90 minutes with patients? I've never spent more than 60 generally in my entire career. And that extra 30 minutes is so golden. It's when I get to know about their actual goals, their backstory, their life, how their symptoms fit into their life, how I can help them restore whatever aspect right now is bothering them the most and put it in context within their life. So it is absolutely beautiful. And I'm grateful every day.
And it's so fun getting to work with brilliant minds like you because we get to share cases, we get to discuss we see a lot of complex things because we're so obsessed with the research and we're so interested in people's stories and exams. And so we have complex case clinics where we really try we have a patient coming in from the Midwest tomorrow where we're going to both examine her together to really understand what is going on here. And so we have a question in the chat box, that I think is really important. This idea of what if it's not stress and what if it's not urge? What if it's this full, like this non-sensory incontinence that happens? I'm on vaginal estrogen. I've stopped liquids. It just is like what do you think about those patients?
Yeah, I think there's a whole nother several components of leakage that we didn't talk about today because they're not as common, but there's things like urethral diverticulum that can they're little outpouchings of the urethra that can cause dribbling. This is really common like right after urination, sometimes worse with sex. So again, that's one other thing. There's urinary fistulas, which are an abnormal connection that sometimes happen after childbirth or hysterectomy or other pelvic surgeries. And a lot of times, I often see women that are like, you know what, I just don't like all this vaginal moisture. And after we rule out every other cause, it's just a really healthy vagina or, during ovulation, the cervix makes a lot of thin, watery discharge. So again, sometimes it's coming from the vagina, and sometimes we actually do a test where we have them take a medication that turns the urine orange called azo or pyridium to see on their pad when they have leakage, is it orange, meaning urine, or is it just a really healthy lubricated vagina? So there's lots of things that we can do to help evaluate for leakage, but there certainly are several types. There's also another one very common in men called overflow incontinence, where basically for men the prostate is so large it's kind of obstructing the urine outflow, and they just get little dribbles. Generally, this doesn't happen often in women because we don't have a huge area for obstruction unless there's really advanced prolapse. But again, so many other types of leakage that really do need a full history exam and workup.
And I think that's the magic words there is like if you have leakage, it matters to specialists who really want to go in and dive deep. It's not something you should ignore, like because it could be the sign of something else as well. So you need someone who is curious, who really wants to understand your anatomy and figure out what's going on for you. And so I think it's really important that you're here and that you're asking these questions. And sometimes you have to see more than one person, right? If you've, say, gone to somebody who is a specialist in incontinence, it's also okay to get a second opinion. And anybody who doesn't want you, I love when patients see other people and I can learn from other ideas and other thoughts. And so any doctor who says, oh, you never should get a second opinion, it's my way or the highway, please run. Like these, it's okay to get second opinions. And sometimes a good exam needs to happen. And sometimes it takes a couple eyeballs to get a really, really good exam.
100%. And that's a great question. Thank you for that.
All right, let's go into Bulkamid. We've gotten a lot of questions about Bulkamid, really good questions. Is there any concern for retention, meaning you cannot pee after you get, so Bulkamid, you've got this urethra and then you get these cushions that make it all a little bit tighter, right? It's filler for your urethra. It's so cool. And I'm so thrilled they invented it. But can it make it so you can't pee?
So yes, it is uncommon, but yes, that's possible if we overbulk. So if that should happen, what we do is we put in a very small catheter, very small, which kind of helps those little cushions kind of smush out a little bit to allow for a better channel through the urethra. That is a temporary condition, and sometimes that's also just from a little bit of swelling from the procedure. Generally, the catheter is removed within a few days. And again, that is uncommon, but possible.
And what age group, at what age can you get or not get Bulkamid?
So the lovely thing about Bulkamid is there's no restrictions. So if you're a young person not done with your childbearing years and you want to have another pregnancy, it's absolutely safe to get pregnant with Bulkamid. There's concerns about slings still, even though the data is in support. We generally don't recommend slings until after childbearing is complete. But really, at any age it's bothersome to a woman, bulking is absolutely okay. Slings are still a little controversial.
Is there ever an exam that you see or a story that you see where you're like, I just don't think Bulkamid's going to be the right thing for you?
Yeah, that's a great question. When I see really severe leakage, when a woman has a really, really hypermobile urethra and leaks with very minimal effort, like, just shifting herself in her chair or just bending over, things that are very, very low force. I'm concerned that putting bulking in isn't going to be enough. Generally, this is where we need to support the urethra because a sling provides like lateral and underneath the urethra support. So it's almost like it's giving the urethra like a big hug from the outside to support it so that women don't have leakage. And this, again, is the gold standard for severe types of leakage, which are also called intrinsic sphincter deficiency. So when I see a really hypermobile urethra with severe leakage, I generally push patients towards a sling, though, of course, we do shared decision making. If they want to try bulking agents first, that's absolutely okay, because the nice thing about bulking is it doesn't preclude a sling surgery later. So there's nothing lost other than a little tiny bit of downtime. But generally, I will try to educate a patient and let them know that slings are generally more successful. And that's.
Are you guys learning? I'm learning so much. Are you guys learning so much? Say yes in the chat box because you like when we do these live events. What about in Canada? Can you get Bulkamid in Canada?
Ooh, gosh, that's a great question. I think we could reach out to the Boston Scientific reps to see, but I am not 100% sure on that.
All right. What about how long? Oh, okay. Is Bulkamid for leakage or for frequent urination, Dr. Vaccaro?
Yeah. So Bulkamid is for leakage with coughing, sneezing, lifting, laughing. So it's a treatment for stress incontinence.
Fabulous. Okay, I'm going to take this question, even though you're doing the questions tonight. Can a woman going through perimenopause who has bladder urgency start vaginal hormones as early at 46? Yes, I wish you
100%.
had started it 10 years ago. So vaginal estrogen or vaginal DHA, local hormones are safe for we give vaginal estrogen to little girls with labial adhesions. We should give women who are breastfeeding vaginal estrogen to help with the genital and urinary symptoms of lactation. Vaginal estrogen is like microdosing. It's like buying a hydrocortisone cream for a bug bite at CVS. It's microdosing these local hormones that heal the tissue, that restore it, that keep it acidic to fight infection. So if you have any symptoms of frequency, urgency, leakage, or you have urinary tract infections, vaginal estrogen is so safe, is so effective. The dosing, there's different forms. There's inserts, there's creams, there's suppositories. And so if you actually go on our website, rachelrubinmd.com, and you go to education resources, you can download a piece of paper that says the dosage and the type of hormones, and it links to our YouTube channel, which we're going to put in the chat box, that goes over all the questions about vaginal hormones. So it is so safe, it's so effective, and your doctor should be prescribing it for you. And if they're not, you bring that piece of paper that has a link to our YouTube channel, shows the symptoms and how they should write the prescription, so that you can go armed with evidence-based information. Because this is, and as I said, sign up for our newsletter and stay tuned, because there's some big news coming out that gives even more reinforcement of why, we have to loudly teach doctors that it's so safe to use. Okay, sorry, I had to do that one. That's
I love it.
okay. More questions. We got a lot of sling questions, and I think it's really slings. People are very nervous about slings and surgery. They say, think it's because I think you said this, it is truly gets confused with the old style mesh from, sort of prolapse repair. Everyone hears the word mesh and they think, oh my God, it's scary. How do you sort of tell people that they're getting confused? Just like the hormones are dangerous, where they're actually not, because they're thinking about old school hormones that we don't really use anymore.
Yeah. What I generally do is sadly flood them with information written by the American Urogynecologic Society and the Society for Female Urology, which both had a consensus statement about the safety of mesh slings. So both organizations, these are national organizations, came together, agreed on language to put out to patients. Because of so much confusion, women were not getting treatment for stress incontinence because of all these fears. So there's all these women that were just suffering because of the fear of mesh slings. And again, in my fellowship, this was a huge deal in the late 2000s when a bunch of prolapse mesh kits were coming out on the market and all the bad things started happening. So now prolapse mesh kits are not available anymore, but they're very much different than slings, which have been out for almost 30 years now. and are a very, very tiny strip of material that's there just to provide a hammock to re-support the urethra, to recreate a natural support of the urethra that's usually lost during childbirth or even just carrying a pregnancy. So even women that have C-sections still can have stress incontinence just by the fact of carrying a large mass, i.e. a fetus, for 9 months. It can cause a lot of stress on the pelvic floor. So I try to educate them. I give them, again, position statements. I sometimes read from the OGS handout, which basically states that slings are the best studied incontinence surgery in history, and the FDA supports the safety and efficacy of mesh slings. So usually when they read that and they see, oh, the FDA supports the safety and efficacy, the evidence shows safety and efficacy, what are the true risks? And I go through that with them, again, like a 1 to 2% risk of mesh complications, which again, generally speaking, is a mild breakdown in the vaginal incision, which just means we have to close the incision again. These are very minor complications, especially in well-experienced hands. Now, certainly, if you go to someone who does one sling every 10 years, there might be a higher risk of complications, but in someone like a urogynecologist or urologist that's doing these procedures very frequently, the safety is extremely high.
And what about if you have a sling and it didn't work? Can you do another sling? Do you get Bulkamid at that point? What happens if the sling fails, and why does that happen?
Yeah, so about 10% of women will not be completely cured with a sling. I find most of the time, not all the time, but most of the time, they're having different kinds of leakage. So all leakage, again, is not the same. So leakage from stress incontinence is due to poor support of the urethra. If we fix that and a woman still has leakage, oftentimes then it's the urge leakage where I feel like I have to go, I have to go, I have to go. And that requires a whole nother treatment. Again, that's pelvic floor PT, that's Botox, that's sacral nerve stimulation. So these are two different forms of leakage. So oftentimes in my practice, when I see a woman that says my sling failed, and we get into the details, it's usually now she's having the other kind of leakage that needs other therapies. However, if it is still stress incontinence, meaning it's leakage with coughing, sneezing, lifting, laughing, then we do a repeat sling, which sounds crazy. It's like, wait, why are we doing the same thing and expecting different results? But oftentimes, putting in a second sling, especially what we call a retropubic full-length sling, has a 70% chance of success. So if we're doing a repeat procedure, the success rate goes from 90% to 70%, but still a repeat sling has the highest efficacy if it's a recurrent stress incontinence. So, you can do bulking, but it is not the recommendation.
All right, so if you've got urge incontinence, like, oh my gosh, I got to go to the bathroom, I can't get there fast enough, and when I jump up and down and do burpees during my exercise, I leak, where do you start? Do you start with stress? Do you start with the urge? Because there's different treatments.
Yeah, so I generally ask what is the most bothersome. Usually one is more bothersome. Like one is like, oh, well, if I, only leak if I'm at the gym, but I'm leaking constantly with urge incontinence, like every day I can't get to the bathroom, I'll start with urge incontinence therapies. If they're actually perfectly equal, they're leaking equal amounts of time and they're bothered equally, oftentimes I will recommend a sling and Botox at the same procedure. So it's one anesthesia event treating both conditions at the same time. And generally that is very effective. The only downside to that, obviously, is the Botox wears off over time, so then would need to be repeated in an office setting. But at least a woman with one anesthetic event can get both things treated at the same time.
I'm going to give a quick plug. Dr. Vaccaro is doing a really cool study on urgency. So if you're someone with urinary urgency, this will take 5 minutes. You have to fill out this survey. It's in the chat box here. It'll take 5 minutes. We have to do research. We can't not do research. And so that's what our practice, again, if you don't sign up for our newsletter, you're crazy. It's so good. You can see pictures of my kids and learn about menopause and sexual health. So, but we put out these surveys. We put out all sorts of research. We're publishing really cool things. So we would love for you to click on that in the chat box. We'll do a couple more questions. I know there are so many, which is great because these are all going to turn into YouTube videos that Dr. Vaccaro is going to make sure that we add to our answers for you. They're asking about Bulkamid for men. It is not yet approved, but there are people studying it. And so I know there are people playing with this for men. Men do get leakage as well. We've gotten the question question of if people can do come in for the day and get Bulkamid with you at the same time that they see you. This is where we really like virtual visits first and then
Yeah,
planning ahead for things. Would you agree with that?
absolutely. Absolutely.
So we've got lots of ways to get you, you'll hear what you're interested in and obviously plan for your visits because we have people coming in for all sorts of different things, whether it's sexual health conditions, pelvic pain conditions, menopause, hormone therapy, and obviously incontinence issues. So before we go to the last couple questions, let's see, and I want to give a big shout out. I don't know if she's here today, but none of this would happen without Jen from our office.
Yes.
Today is her birthday. So everyone just do a quick happy birthday in the chat box so Jen can feel the love, which is great. So, okay, we're going to launch a quiz because we got to make sure you're all awake. So I am going to launch a quiz. I leak. Oh, they're going to actually write it in. I leak when you're going to put an answer in. All right, let's see if we can get at least. We got a lot of people on this call. So it's all anonymous. No one's going to see your name. It's all an answer. Let's see. I leak when we got one happy birthday from Jen. Okay, only one people? Come on. You asleep? I'm asking them to do too many things at once, I suppose. All right, we've got more than 20 people have answered. I leak when Oh, we got extra. All right, we got a bunch of happy birthday Jens. Okay. I'm gonna close it in 5, 4, 3, 2, 1. All right, we got 40 something. Let's see, view details. Share results. Oh, let me see if this works. Oh, it doesn't work. Wait, hold on. I don't know if you can see it. I leak when I sneeze, when I hold my pee too long, when I run and walk, when I cough, when I jump, when I know a bathroom is too close, when I laugh, when I sneeze. Oh my gosh, when I run, when I walk, when I cough, when I try to hold it too long, when I lift, when I sneeze, when I go running. Oh my gosh, when I do more than 100 double udders. I don't know what that is, but you sound amazing. When I bring in groceries from the car, I can't even get to the kitchen first. You are all not alone. Let's see. Treatments. What's that question? Let's see. Okay. So which therapies sound best to you? Does it seem like you'd want to try any of these things? Would you want to try Bulkamid, pelvic floor physical therapy? Let's take it to the people. What sounds interesting? All right, I'll let people answer that. We got some questions on azo. So when do you tell people what is azo? Can you drink azo? And when do you tell people to use azo? We're getting all sorts of questions about azo.
Yeah. So azo is phenazopyridine, which is basically a topical numbing for the bladder. You take it by mouth, but as it filters through the system, it's processed in the kidneys and ends up in the bladder, and it basically numbs the bladder so that the bladder has less urgency and pain. It's usually used when you're having UTI symptoms, but I commonly use it in patients that have bladder pain syndrome. I generally don't use it in overactive bladder because it's not, again, supposed to be a long-term therapy. It's generally given for short-term therapy, again, like in conjunction with a UTI while the antibiotics are starting to work. It is sort of like a derivative of Tylenol. So Tylenol can influence your liver. So I think that might be the concern with alcohol. I'd have to really dive into that. Again, usually patients are using it for a very short time. So generally, I don't counsel them on limiting alcohol if they're using it for a very short period of time, because that's not going to cause long-term liver issues. But again, not really in the algorithm for treatment for urgency or stress incontinence. It's really more for bladder pain and preventing pain with a UTI.
All right, our results are in. Pelvic floor PT and vaginal hormones. I'm a little disappointed. Vaginal hormones is only 61% answered. The other 40% of you need to go to our YouTube channel and learn why it's so important. That is the foundation of health, of vaginal and bladder health, is vaginal hormones, pelvic floor physical therapy. We love our pelvic floor physical therapy.
We do. They're magicians.
Just Google it, pelvicguru.com. There's all sorts of ways to find pelvic floor PT. If you get a knee replacement, you go to physical therapy. If you leak, you should go to physical therapy. A lot of interest in Bulkamids, which I agree, it is so cool. It's such a cool therapy. And people are asking sort of when is the time that I should be thinking about a sling or I should be thinking about some of these things. And really it's, it's you deserve to have the menu and decide, what is right for you to see is it something, it's not a one size fits all. The menu is there that you can pick and choose from, and you got to get your, everybody watches Instagram and is like, well, what should I do? Instagram, what should I do? And the reality is Instagram cannot tell you what you need to do. You need to figure out and get your team together to figure out what is the right treatment for you. So you are gathering data, you're listening to us, and then you can go to your clinicians and have educated conversations because you are now educated. And if they don't sound like they know what they're talking about, maybe you should see, get another opinion because you can. And that's really what is so helpful. Any last words? I know we didn't answer every single question, but we are going to look back at the questions to make sure. You know what I see here that is just the most beautiful thing in the world, Dr. Vaccaro, is someone just wrote, this Zoom gave me hope.
I saw that. I love it. I love it. That's what we, right? That's what we do. Spread hope, optimism, treatments, quality of life. I love improving women's quality of life. It gives me so much joy.
We are so thrilled. And whether you treat yourself through hormonal options, through trying things like testosterone, which can bulk up the urethra, whether you do physical therapy, whether you try medications for urgency, whether you, do things like Bulkamid, slings, or InterStim, sacral neuromodulation, it's really incredible what the toolbox is looking like. And I always tell people we're not magicians. We certainly are. We don't have magic. But when we get to know people and we meet them where we are, we really talk about your goals and what you care about and the fact that for many of our patients, sexual health matters, feeling like yourself matters, feeling good in your own body matters. We have such a good batting average. We give so much hope. We help so many people. And I can't not want that for everybody. I deeply want that for our patients, our friends who are here from Alaska, who are here from Canada, who are here from all over the world. I want everybody to invest in their quality of life, invest in their health, and really invest in their strength, right? Their physical strength, their bladder strength, their pelvic floor strength, their strength of their human connections, their strength of their relationships. So that should be the sort of the new mantra going forward. We want everyone to sign up for our newsletter, rachelrubinmd.com. We want everybody to come see us if you think it would be a good fit and you want to travel either to Washington, D.C. or to our practice in LA, or if you have friends that do that. But please follow us on social media, say hello, give us more content for videos that we can make to help more people, because it is with information and education that you all can make excellent decisions for yourself, truly. Dr. Vaccaro, take us home, tell people to follow you and give them your handle again in the chat box there. Any last words on incontinence?
Just don't suffer. Just see what someone, get evaluated. Do not be afraid or embarrassed to talk to your clinician about your pelvic floor concerns, because there's lovely therapies out there. You just need to ask the question. And if your provider isn't willing or doesn't know how to treat it, just ask for a referral again to urologist or urogynecologist.
Everybody have an excellent evening. Thank you for joining us tonight. And if this was helpful, please let us know and we can do more topics and bring you more information. Have a lovely evening.
Thanks for your time. Good night.